Medicare. I'm pleased to take this issue on along with Mr. Levin, as this is my first hearing as the new subcommittee chairman. This is the second hearing in a series held by the Ways and Means Committee on this crisis, and today we'll explore opioid addiction and treatment in our Medicare population and ask the question how Congress can do more to improve detection, education, prevention, etc. Like many states, mine, Illinois, is experiencing a notable increase in opioid-related overdose deaths. According to the Illinois Department of Public Health, there have been 44.3% increase in drug overdoses from 2013 to 2016. I know this is consistent with other states and other experiences. Approximately 80% of drug overdose deaths in 2016 were opioid-related. Nationally, more than 42,000 Americans died from opioid-related drug overdoses in 2016, according to the Centers for Disease Control. That's over 115 people a day, or the equivalent of over 14 people who would have lost their lives in the course of this upcoming hearing today. And while those are statistics, and the statistics are compelling, we're talking about sons and daughters, brothers and sisters, mothers and fathers, those who are dear to us who are struggling with this in and around our communities. With 10,000 baby boomers joining Medicare each day, we must harness innovation, technology, and data to get ahead of this problem. And unfortunately, there's a lack of available data regarding the Medicare population and the extent to which opioid abuse, overprescribing, and diversion is an issue for seniors and the disabled. Additionally, gaps in coverage for those that suffer from opioid addiction exist as well. To help us examine what states are doing to address the opioid epidemic, we have Governor Phil Scott to discuss the tremendous efforts that the state of Vermont has undertaken to battle the crisis through expanded treatment options and substance abuse disorder management. We have representatives from 2 health plans that serve Medicare beneficiaries to discuss how payers are managing care for those that suffer from substance abuse disorder and the hurdles they face in doing so. And finally, to round out our witness panel, we have 2 representatives from the medical field to discuss both medication-assisted treatment and other intervention pain services. I think all of us approach this issue with humility. All of us represent constituencies that are being overwhelmed by this crisis, and all of us are looking for solutions. And I think our constituents have sent us here with the disposition to get things done, and I look forward to working with both sides of the aisle to come up with common sense solutions, to look at the things that work and celebrate them and pursue them, shun the things that don't work, and to do everything that we can to relieve this crisis and bring hope and optimism in a field that is really quite overwhelming. Now I'm pleased that the ranking member of the Ways and Means Committee is here, Mr. Neal, and I'd yield to him for the purposes of an opening statement.
Thank you, Mr. Chairman. Let me congratulate you on your first hearing here. I would remind all that you served with me on the Tax Subcommittee, and it was very clear that you decided your future would lie in the Health Subcommittee after that. Mr. Chairman, I'm pleased that we are holding this hearing to identify solutions to address the opiate abuse and dependence, specifically in the Medicare space. Although overdose rates are highest for people 25 to 54, this public health emergency also affects Medicare beneficiaries. Everyone in this room has a family member or knows someone directly impacted by the opiate epidemic. It could be somebody down the street. It could be somebody in the next room. In my home state of Massachusetts, last year there were 2,094 confirmed opiate-related deaths due to abuse. I thank my neighbor to the north, Governor Scott and his Health Secretary, Gobet, for joining us today. We share a border, and it also means that we share a common challenge fighting the opiate crisis. Massachusetts Governor Charlie Baker, like Governor Scott, is working to employ all tools in this fight, ranging from expanding Medicaid coverage to provide treatment availability, data analytics, and treat addiction while stabilizing and supporting families. Opiate abuse and related deaths take a toll on all of our communities and on all of our families. There is no single cause, and there certainly is no single solution. Expanding Medicaid under the Affordable Care Act to low-income working Americans who previously could not afford insurance has been the most significant step in recent years to stem the tide of opiate crises. Providing access to critical substance abuse and mental health services that previously were prohibitively costly has also worked. We need to look to Medicare beneficiaries' ability to access treatment, as oftentimes providers aren't available to meet the needs. We know there are significant gaps in coverage and access under Medicare. For example, Medicare does not cover outpatient treatment programs that provide comprehensive opiate addiction treatments, nor does Medicare cover methadone for addiction, which is often the treatment of choice for longer-term addicts. I recently introduced legislation that would allow methadone to be covered for outpatient services under Medicare. We also need to work with our partners to identify best practices. Late last week, I sent a letter to the Energy and Commerce Ranking Member Pallone about 14 Medicare plans and to ask them to help compile the best practices that they're aware of to address opioid-related disorders. Evidence-based tested activities that are helping patients turn the corner will help us design sound policy. I look forward to these plan responses, and I hope Dr. Paz from Aetna today will share his knowledge about what they're doing as well. We also need to explore how substance abuse is affecting children and families. The epidemic is fueling a rise in caseloads for children and adult protective services, for foster care, and also for caregivers as they attempt to battle addiction. I'm pleased that our committee has worked together on this bipartisan basis on legislation to support families and to help them keep children safe who would otherwise be in foster care while they can now remain safely at home with proper monitoring. We hope we can continue this partnership because we have much work to do. I hope that as we move into the following year, that we will not endorse or embrace plans to cut efforts that would in fact undermine what we're attempting to do here today. For example, the Social Security Services Block Grant is the largest source of federal funding for child protective services and the only major source of federal funding for adult protective services in most states. We have a lot of work to do, and Congress could play a positive role in partnering with the states to provide resources and help to eliminate federal barriers to treatment and access and support families and law enforcement. And Mr. Chairman, to you for holding this hearing, appreciate it. To also point out something that you and I have talked about a number of times. There are now 2 million people on the sidelines who formerly were in the workplace battling this epidemic. And when you look at labor participation rates, it has had a huge impact on what has happened. So this is a very important hearing. Thank you.
Thank you, Mr. Neal. I'll now recognize Mr. Levin for his opening statement.
Thank you, Mr. Chairman, and congratulations. We all look forward to working with you. You are surely a very articulate, knowledgeable person. We look forward to it. And thank you for letting us, in essence, make 2 opening statements. Mr. Neal comes from a state, I think, where there's been a strong wrestling with this issue. The same in Michigan. Welcome to the witnesses. A son, Matthew, lives in Vermont and is active representing mainly education groups in the halls he may have bumped into you. Mr. Chairman, the opioid epidemic is an enormous societal problem that demands a concerted effort at every level of government. The death toll is astonishing. 91 Americans die every day from an opioid overdose, with 5 dying every single day in my home state. We have to stop this killer. Despite the urgency of this crisis, it's clear that although President Trump has declared a public health emergency, to date, the administration has not taken significant steps to address it. Last year, President Trump proposed a budget that would radically alter the Medicaid program while slashing its funding by $1.3 trillion. Medicaid is the largest payer for behavioral health services. It funds detoxification, maintenance therapy, medication assistance treatment, and other crucial services. We cannot claim we are serious about addressing this crisis on the one hand, while gutting one of the country's most important sources of treatment on the other. These efforts come on the heels of efforts within the Affordable Care Act that would have, I think, if repeal had occurred, undermined these efforts. I'll look now to the future and leave those comments for the record. At this crucial time, the administration has also undermined the Office of national drug control policy, which for decades has helped fight drug abuse in this country. Last year, we fought against the administration's efforts to eliminate all funding for the Drug-Free Community Program, an effective multi-sector community-based drug prevention program that was really started by a fellow member of this committee, Rob Portman, when he served, and myself in 1996. There have been thousands of community anti-drug coalitions that have received seed money because of this program, the appropriation level now $90 million. This year, we heard once again that the administration intends to propose undercutting this office by eliminating its oversight of drug control and prevention programs. And I must confess, I was really alarmed with so many when the administration suggested placing a 24-year-old with no relevant experience in this second highest position. Through the Drug-Free Communities Act, we've had so much contact with this office. It needs the most talented personnel effort. A coordinated federal response to this crisis is possible, but it will require a dramatic change of course. We must take immediate steps to ensure that we are effectively implementing programs that prevent flooding of our communities with unnecessary prescriptions. In Michigan, a state of less than 10 million, more than 11 million opioid prescriptions are written annually. 11 million. This is more than enough to provide each resident of my home state with a bottle of opioids each year. Addressing the pervasiveness of this will require a broad-based effort to revise clinical guidelines with the goal of improving provider behavior, leadership at the state and federal level to monitor harmful prescriptions and marketing practices, and other immediate steps that will reduce the prevalence. I just close. We all, Mr. Chairman, encounter this problem every time we go home. Mm-hmm. Do we not? Every time. And we hear of deaths. It's younger people, but also people not so young. People sometimes under immense stress. And I think with the leadership of this subcommittee and the entire Ways and Means Committee, Energy and Commerce, and the Congress, we need to do everything to fulfill our obligation. All the answer isn't in Washington, but some of them are. So we look forward to the testimony of you distinguished members of the public sector. Thank you, Mr. Chair.
Thank you, Mr. Levin. Let me describe how we'll move the traffic now. We've got two panels. The first will be the governor, and we'll have 5 minutes from each of the witnesses. And if you're getting a little lengthy, I'll kind of tap it gently, and you'll get it, and so forth. But I think most folks have had an opportunity to read all of the statements. But to give us an introduction of the governor is the distinguished gentleman and our friend from Vermont, Mr. Welch, who has this distinguishing gift of being able to tell someone to kind of go jump in the lake, but with such charm that you kind of look forward to the trip, actually. So, Mr. Welch, would you...
and there aren't that many lakes in Vermont either.
Can you introduce the governor? Your mic.
I thank the chairman for that dubious introduction, but I'm not here to tell you to jump in a lake. I'm here to thank you for having a bipartisan hearing on an incredibly devastating problem. And as Mr. Levin said, we here in the federal government can provide some help, but the hard work is done with first responders, with mayors, with governors. One distinguishing thing about Vermont is we embraced the challenge on a bipartisan basis. The Democratic governor, predecessor to Phil Scott, Peter Shumlin, spoke in his entire address in 2014 about the opioid crisis. And I remember talking to some of my colleagues here saying, Peter, why would you be advertising that bad news? But then as we talked, acknowledging that that was a devastating issue in their own communities. Phil Scott was then lieutenant governor. He has taken up the leadership in Vermont now to follow through. And we have this bipartisan approach to trying to address the tragic circumstances of opioid addiction. So I thank all of the members of this committee. Mr. Chairman, thank you for being here. The ranking member, Neil, is here as well. It shows the urgency of this committee, and all of us are ready to work with you. Thank you. And I give you the governor of the state of Vermont, my friend, former lieutenant governor, now governor, Phil Scott of Middlesex, Vermont. Barry.
Governor, you're recognized. Thank you for being here.
Thank you very much, and thank you, Congressman Welch. We served together in the Senate not long ago. Chairman Roscom, Ranking Member Levin, I do know your son. I played hockey with him a few years ago. He's a very good hockey player. And members of the subcommittee, I want to thank you for the honor of appearing before you today. My Secretary of Human Services, Al Gobey, Commissioner of Health, Dr. Mark Levine, and Director of the Blueprint for Health, Beth Tansman, are here with me as well. As was mentioned, in Vermont, the governor and lieutenant governor are elected separately. So in 2014, when then Governor Peter Shumlin, a Democrat, devoted his State of the State address to the opioid epidemic, I was sitting there listening as the Republican lieutenant governor, and I must admit, I was more than just a bit skeptical. I was concerned calling so much attention to this problem would damage our image and hurt our state. And sure enough, initially, many at the national level portrayed this as only a Vermont problem. We now know all too well this was and is a national problem. Governor Shumlin was right to focus our attention on this epidemic, and I have since learned that the incredible devastation opioids have had on our state and our people. I have met countless Vermonters impacted by addiction, some in recovery, some still struggling, and some who've had their families torn apart, changing their lives forever. We have made a lot of progress in Vermont, much of it with support from you and our federal partners. Although today, I approach you humbly because we have not yet solved this problem. Even with our small population, we see 2 Vermonters die from a drug overdose every week. And nearly every day, a baby is born exposed to opioids, something I've highlighted as one of Vermont's biggest challenges. We have some of the best access to treatment in the nation, but too many Vermonters who need treatment have not sought it. And while Vermont's rate of overdose deaths is the lowest in New England, we still lost 106 people in 2016, and 2017 looks like it will be similar. Tragically, we also experience high numbers of children under the age of 5 who come into state custody due to this crisis. And I think we all would agree these kids don't deserve this. They need a better start. We have focused on what I refer to as the 4 legs of the stool: prevention, recovery, treatment, and enforcement. On my first day in office, I established by executive order the Opioid Coordination Council. This council is made up of a wide range of perspectives, life experience, and different political philosophies. Importantly, this includes those who have suffered from the addiction themselves. I handpicked them and tasked them with providing recommendations to improve Vermont's response in each of the 4 legs of the stool. We know that too many Vermonters become addicted through prescription pain medication. Therefore, the state implemented strict prescriber rules around pain management and a prescription monitoring system. So for the first time, we are beginning to see a reduction in prescribed opioids. Unfortunately, we still prescribe 3 times as much as we did in 1999. Vermont has also made Narcan widely available to first responders, law enforcement, people with addiction, and family members of those suffering. We have aggressively used a screening, brief intervention, and referral to treatment model, also known as SBIRT, to prevent the progression of addiction. Enforcement is another important piece, but we are all in agreement. We can't arrest our way out of this. Our courts, local police, and state's attorneys have become important partners in addressing this epidemic, and we address it as a public health issue. To treat opioid addiction, Vermont operates a medication-assisted treatment, or MAT, system called Hub and Spoke. With the support of our federal partners, we established a health home for Vermonters with opioid addiction. Through well-coordinated and comprehensive services, we treat opioid addiction like we do any other chronic condition. Our hubs provide all FDA-approved medications. They also provide critical nursing, counseling, and care management. In our spokes, primary care offices prescribing buprenorphine are supported by nurses and counselors who offer more complete care. Finally, coordination between hubs and spokes assures the patients receive the appropriate level of care as they need it. Vermont and the federal government have been effective partners in tackling healthcare challenges for many years. It is in this collaborative spirit that I offer 4 areas where together we can improve our response. First, Medicare needs to treat this as the chronic condition that it is. I've sent a letter to the Secretary of Health and Human Services asking that CMS work with Vermont and engage Medicare in Vermont's hub and spoke system. Working with our federal partners, we hope to develop a path to make this a reality. Second, we need to make sure that SBIRT is fully supported within the billing system so Vermont can sustain and expand this important work. Third, we ask you to consider giving states relief from the IMD exclusion, which prohibits using Medicaid funds in mental health or treatment facilities of 16 or more beds. Finally, our small state could benefit tremendously from nationally supported research in the areas of alternative pain treatment and from expanded coverage for alternative chronic pain management. In closing, I'd like to thank you for the opportunity to address this committee. We have made great progress over the years, but we have much more to do if we are to improve the health of Vermonters and all Americans to truly end this crisis and this epidemic. Thank you.
Thank you, Governor. We really appreciate your insight. Don't go anywhere. I'm just going to briefly introduce the other panelists, a little bit of a foreshadowing, and then we're going to come back for questions with you. So our second panel, we're going to hear from Dr. Ramsin Benjamin, president at Millennium Pain Center located in Illinois, Bloomington, Illinois. Look forward to hearing from him. And our next few witnesses, I'm going to yield to our colleagues. I'll now yield to Mr. Thompson for the purpose of an introduction.
Thank you, Mr. Chairman, and congratulations on your new chairmanship. And thanks for having this hearing. Mr. Chairman, thanks for the opportunity to introduce and to welcome to the committee Dr. Jason Kletter, the president of Baymark Health Services. Dr. Kletter has 20 years of experience in the addiction field and currently serves as president of the Bay Area Addiction Research and Treatment, headquartered in San Francisco in the Bay Area. His organization operates 20 opioid treatment programs in 5 states, serving 7,000 patients every day. Dr. Kletter also serves as the president of the California Opioid Maintenance Providers and as a board member of the American Association for the Treatment of Opioid Dependence. He has advised both federal and state agencies, providing input on accreditation guidelines, physician training, and various state policies. As part of California's Hub and Spoke program, modeled off the program Governor Scott described earlier, Dr. Kletter's BART program in Antioch, California, will serve as the hub to a handful of spokes that will provide treatment to constituents across my district. And I just learned today he's also a part-time resident of my hometown. So Dr. Kletter, thank you for your testimony. I look forward to hearing about your experience in the field and understanding how this committee can best support your work. Thank you for being here.
Thank you, Mr. Thompson. Mr. Larson?
Thank you, Mr. Chairman, and let me echo the sentiments of the members of the committee and congratulate you on your new chairmanship. And I know how well you work with Mr. Levin, and we thank you for hosting this very important hearing today. It's my honor to introduce Dr. Harold Pause, who is the Executive Vice President and Chief Medical Officer for Aetna in my home state of Connecticut. Aetna is blessed that it has probably one of the leading thought leaders around healthcare in the world in Mark Bertolini, and Connecticut as a region is blessed to have an industry that is focused on this, including David Cordani from Cigna as well. But as head of the Aetna's enterprise-wide opiate task force, Dr. Paz is responsible for a company-wide strategy to prevent the misuse and abuse of medications, something that is critical in this epidemic as it continues to savage this country of ours. Under his leadership, we've been able to follow example and hope that we are able to follow examples that the private sector is setting and find ways to help our public health system, especially Medicare and Medicaid, effectively and humanely care for those suffering from addiction. Aetna has used its valuable data to help identify what they call super prescribers and worked with hard-hit states to provide training and supplies of life-saving treatments like Narcan, as the governor mentioned early on. So it is my high honor here today to introduce Dr. Paz. We look forward to your testimony, and we thank you for your leadership and acknowledge that it's not just government, but the private sector, and in fact all of us, that need to work in collaboration to solve this national epidemic. Thank you, Dr. Paz.
Thank you, Mr. Larson. And Mr. Buchanan.
Well, thank you, Mr. Chairman, for holding this important hearing. I also want to congratulate you on your chairmanship. I'm excited about what you're going to be able to do with this committee. I'm pleased to welcome Laura Huntsfield, Chief Pharmacist Officer of WellCare Healthcare Plans based in Tampa, Florida, part of the region that I represent. They do a lot in our region, but all throughout the state and the country. In this role, she helps implement programs to prevent opioid abuse, helps members living with chronic pain, and helps members battling addiction. WellCare ensures 4.3 million members nationwide enrolled in Medicare Advantage, Medicare prescription, drug plans, and Medicaid. Currently, this does not include mental health counseling. Yet, according to the HHS, approximately 13% of people aged 65 and older suffer from mental illness. And with that, I'll yield back.
Thank you all. Now we'll turn to make inquiries of the governor and his team. We're going to break with our normal tradition, and by agreement, we're limiting our members to 4 minutes. And with that, I'll yield back to Mr. Buchanan to begin the inquiry.
Well, thank you, Governor, for being here. We also have a Governor Scott in Florida, so I don't know if you're related or not, but if you're nearly as talented as he is, you got to be a heck of a governor.
If there's any controversy, I usually blame him.
Oh, do you? But let me just say, we had back 7, 8 years ago, I had a lot of members from Kentucky and Tennessee and other places, everybody be coming to Florida. We had 1,300 pill mills that were there, and they'd come here because we didn't have a database, and it was a disaster. We were losing 10 people a day. We've shut down a lot of those pill mills, but they've moved over to heroin and fentanyl and other drugs in our community. In fact, my main county is the epicenter of Florida per capita with a lot of these drugs. But I read something the other day, just was a shocking statistic from the AARP that deaths from opioids, and of course being in Florida, we have a lot of seniors. I think 60% are 60 and older in my area. But from deaths, they have increased sevenfold, 7 times for seniors 65 to 74, because you always think sometimes about just younger people, over the past 15 years. This is an absolute tragic thing, and I guess I'd be interested in what you've learned from Vermont in terms of a lot of your seniors. Let's just take that initially. Any thoughts that you've got on that?
I'll start off and then let my secretary take off from there. But we are seeing, I think a lot of it is the prescription rate amongst seniors across the board that they store in their medicine cabinets and so forth. We have a prescription drug take-back program where in the first, what I thought was the first year, they collected almost 6,000 pounds in our small state of Vermont. And I thought that was remarkable. And I said, for the first year, I would expect that with the pent-up reserves. And then they told me that was the 3rd year. And they collected 5,000 the year before and 5,000 the year before that. So that tells me that the prescription rate is abusive over and excessive. So we aren't, I don't believe we're seeing the deaths of our seniors as we do with our youth, but I'll let our secretary answer that.
Let me, just for time, let me get to another question. Somebody had mentioned, I think one of my colleagues, about everybody's impacted, families. My family's been impacted. But what are you doing on a little different score? What are you doing in terms of prevention? I had a mother come in the other day, 4 kids, homeschooled, 2 of them are addicted. So the thought is, to me, is, you know, what do we do to prevent this in the first place? Because once they go through that door, she told me, crying, that she basically, after 2 weeks of being on these pills, the older brother brought it home and got his sister hooked. But in a matter of a couple of weeks, they got addicted, and it's been over a year for both of them to be able to get them off this stuff, and they might have to deal with this the rest of their life. So the impact and the power of these drugs is incredible. And, but I've got a lot of stories like that. I've had 3 mothers come in where they've lost their children, and that's what got me initially involved in this effort. But what's your thought about prevention? Because once they go through that door, in my opinion, it's nice to have all these other things, and it's important, but how do we prevent it in the first place? What more can we be doing on the prevention front?
So, thank you. My answer to that would be is that we need to do a lot more in prevention. Some of the things that we've done is that we've worked with the goal of setting up a prescription monitoring system in our state. We passed a law in 2013, but we had done good work prior to that to try to get a database where we would know what specialties we're prescribing, at what levels, basically so that doctors would know who was prescribing what to their patients, so that we could look inside our state, but also, because we're a small state, to our neighboring states and what was happening with our patients, basically, that could go there for pills. So it's a game of how do you reduce the impact of the pills, because this is a pill-driven crisis. And so anything that can aid that upstream has a big benefit.
Let me just close out, because I want to yield back.
Thank you. I think there's going to be, let me just give you a little housekeeping here. I think there's going to be, we as members have a lot to say. We're going to be well served if we allow our witnesses to give us input. And so keep the hang time on your question a little more limited so that they can come back. You know what I'm saying? So, Mr. Yeah, we're varying from our normal procedure. Mr. Thompson.
Thank you, Mr. Chairman. Governor, thank you for being here. According to the CDC, 42% of workers with back injuries got an opioid prescription in the first year after their injury. And then a year later, nearly 1 in 5 of those patients are still taking the same drug, despite the fact that the FDA has not approved opioids for long-term use. So clearly, these people are still suffering serious pain, or they're addicted. So how do we make sure that folks, workers who've been injured on the job and are under the protection of the state workers' comp system, are getting appropriate treatment for their injury? And how can we ensure that they have access to treatment if they become addicted?
Good example.
Thank you.
How'd I do?
I think that the answer begins with taking a look at the way that pain clinics are formed, and I think you have a witness that'll come up and describe it way better than I can. But basically, there has to be a lot more avenues to treat the pain and to treat the rehabilitation for folks other than just opioids. So while opioids may be an answer, there's a lot of other answers that need to, questions that need to be asked, and potential remedies other than just simply prescribing long-term opioids.
Have you looked at the workers' comp system in your state? I know in my state, I have constituents who become injured, and it takes forever to get through the system, and they rely on the opioids to relieve the pain while they're waiting for treatment, sometimes treatment that never comes. And I'm just concerned that this may exacerbate the entire program.
Do you want to comment?
Yeah, I've lived that life. I was 3 decades in the construction business, so I had numerous of my employees out with injuries and so forth. We have to be very, very careful once we open the door and they are prescribed opioids and prescription drugs to just shut them off without proper treatment. leads them to other methods of heroin, fentanyl, and so forth. So we are monitoring that. We are taking a look at that as we speak with interest as to what we can do to make sure that we have a pathway for them to recover. But because, again, we don't want to just shut them off. We want to help them get through it so they can become more productive citizens back into the workforce, which is so important. And those are some of the opportunities that we see with our Opioid Coordination Council to look for ways that we can break down the stigma, as well as to appreciate when someone has a problem, so that we make sure, again, we want to make sure that we reintegrate them back into the workforce, because we desperately need them in Vermont.
Thank you. Some have said that Medicaid expansion is behind the opioid epidemic, but everything that I've read suggests that the expansion happened in 2014, and this has been going on since the 90s. So, Governor, can you tell us about the role Vermont's Medicaid expansion is playing in your state's efforts to address this epidemic, and just how critical will Medicaid be in the recovery process?
Yeah, so to be clear, we don't believe that Medicaid expansion caused this crisis. And further, if we believe through fact that this is a chronic illness, then each payer should treat it like the chronic illness it is and be able to pay as a benefit for necessary treatment, counseling, et cetera. This really started in the late 90s, and I think that the evidence is clear.
Thank you very much. I yield back.
Thank you.
Mr. Smith.
Thank you, Mr. Chairman. Thank you to our witnesses for addressing, I think, a large problem across the country, rural, urban. A lot of folks, as you know, are impacted. Governor, I'm wondering if you think that the type of management and monitoring necessary to successfully guide patients through the process of medication-assisted treatment programs such as yours are possible under the Medicare program. Or feel free, either one of you.
We do think they're possible, but the letter that we sent to the HHS secretary was basically a request, not that Medicare just simply treat this like a chronic illness and begin to pay for the delivery of services, counseling, or medically assisted treatment, for example, but to actually participate in Vermont's system of care, which is partially hub and spoke, but also other treatment modalities. So it's not enough to just sort of pay the bill. It's about the way in which the services are delivered and organized that we want Medicare to fully participate in like other payers.
Okay, I think you answered my next question, so I appreciate that. And I think the approach, I would hope that there's the flexibility offered to states to address as they see fit. That not often comes from the federal government, but hopefully that can be offered in the future, if you will.
Yes, sir. And what I would add is that recovery and healing should be a part of a conversation with your healthcare provider. And hub and spoke might be one answer. There might be residential treatment. There might be other paths to sobriety and getting back to living the life you wanted to live. And so Medicare should participate in all of that, just like we do with other, illnesses.
There are a lot of Nebraskans, especially in the agriculture community, who are buying their health insurance through the individual market. They're telling me that their out-of-pocket expenses are $30,000 a year, $40,000 a year, with copays and deductibles contributing to that, that really put a lot of access out of reach. And I'm wondering if that will ultimately pose a barrier. Certainly, many of our hospitals are even getting stuck with those copays, unpaid copays and deductibles. And I'm wondering how we might need to address that at the same time we're looking at these issues.
So just an idea. The way that we treat colonoscopies, the way that we treat primary care services under the Affordable Care Act is that those are included, as a benefit. Services like this could be included and not necessarily go against your deductible. And so it's a question of, how you want to set up the insurance marketplace so that people actually participate in, in different types of prevention alternatives. And that would be, for others than I, but I would think we'd have to take a hard look at that.
Okay, very well. Thank you. I yield back.
Mr. Kind.
Thank you, Mr. Chairman, and I welcome you and congratulate you on your new position. Look forward to working with you. Gentlemen, thank you for being here, and I, in particular, have been paying very close attention to the challenge you face in Vermont. I mean, you have a large rural state. I have a very large rural district in western Wisconsin. We face many of the same issues, and we appreciate your insight on this. And I also, Governor, appreciate your opening comments as a former special prosecutor who dealt in the drug world for a long time, that I've had a lot of forums, a lot of listening sessions back home, including with law enforcement, and I haven't met anyone yet who thinks we're going to be able to deal with this through the criminal justice system. This has to be a public health approach ultimately to break the cycle of addiction for us to have any fighting chance to get out ahead of that. So I appreciate your insight on that. Governor, I was wondering if you've been following closely the Trump administration's Commission on Combating Drug Addiction and the Opioid Crisis, because last November they did come out with a fairly detailed report and findings and recommendations that were submitted to us here in Congress for our consideration. Have you had a chance to look at that or review that at all?
Yeah, our team has taken a look at that. We, again, have set out on our own course that we think is working. Some of them were replicated within the report. But we're always looking for new information. And again, one size doesn't fit all, as we've found out, and there are always new opportunities to do something better. So we're still looking at the report, determining if there's anything that we can use to make better use of our system.
Yeah, some of the recommendations are kind of common sense principles that do apply across the board. I mean, increasing access to substance abuse treatment programs. We're going to hear further testimony today on that. Also, under federal law, insurers are already required to cover addiction treatment and mental health services. Many of them aren't, and many of them aren't including them within their networks, and especially difficult in rural areas given what's available out there. They also recommended dedicating more money for treatment overall. They were encouraging greater use of alternative and complementary forms of medicine rather than just a cocktail of prescription drugs that often lead to addiction and then contributing to the opioid epidemic. One of the recommendations, I'm wondering if you had a chance to look at it or have an opinion, is recommending that we give the Department of Labor the authority to start penalizing insurance companies that aren't including it in the network and are not adequately providing coverage for addiction treatment or other mental health services. Is that something we ought to be considering?
So what I would say is that while they were holding their meetings and writing their report, our Opioid Coordination Council, which I chaired, we were writing a report as well, and we came out almost the same on so many issues. It was, really came out right at the same time. And the NGA also has a report that's, there's a lot of common sense in all the documents, so I agree with your points. The last question that you asked, I think that we have to embrace this as a chronic condition. And then if we do, we should make Medicare, Medicaid, and commercial insurers treat this as an essential health benefit like we would kidney disease or some other diabetes or some other chronic condition. So yes, I would think that would be.
The other thing I think we ought to be considering is, since you guys are out front doing a lot of good work and trying to get out, and virtually every state is trying to do the same thing, is some type of national repository of best practices and best evidence medicine, what's working and what isn't, so each state isn't required to recreate the same wheel over again. And interesting, even though we've been going through problems with VA reform lately, we've had some success in a bipartisan fashion implementing certain reforms with the VA Medical Center, especially when it comes to pain management and drug addiction. In fact, in my home area, Tomah, Wisconsin, the VA Center is developing a really interesting model with a tremendous track record of proven results that could become a model of care throughout the country if we do it right. So I would also take a closer look at what the VA has been doing on this front for some time. Thank you, Mr. Chairman.
Secretary Gomez, hold that thought and kind of weave your answer into an inquiry that's coming from Ms. Jenkins from Kansas.
Thank you, Mr. Chairman, and thank you, Governor, for being with us in this subcommittee. Like Vermont, my home state of Kansas is struggling with a nationwide opioid epidemic. In my view, it's particularly difficult for rural states to expand access to opioid treatment services just because of a lack of treatment facilities and trained medical personnel. So Vermont's hub and spoke approach may well be a model for our nation. In your written testimony, you mentioned strategies for prevention, harm reduction, early intervention, criminal justice treatment, and recovery. Your testimony brought to mind just a couple questions I'd like to ask. The first is, it's my understanding that there is a low uptake in the electronic prescribing of controlled substances. And the state of Vermont is the state of Vermont doing anything to encourage prescribers to utilize e-prescribing? And if so, can you just talk a little bit about any pushback the state may have received in implementing those proposals?
Go ahead.
So I had to phone a friend. We use e-prescribing, and according to the smarter people than me behind me, we're good in that area, even though we're rural and small. And so we could get you more information and submit that in writing if that would be okay.
I'd be interested if you had any pushback. Yeah, if you could get back to me, that'd be great.
But about the pushback, I think what's interesting, the way the congressman from Vermont was introduced as somebody who could, politely tell somebody to jump in a snowbank. In Vermont, it's really hard to fight back common sense because we're so small and we all know each other. And so we don't run into that as much as you might think.
Okay. I'm told that substance abuse community clinics and residential treatment centers still use telephone, paper records, and faxes to communicate with each other and the larger medical systems. I've introduced H.R. 3331 with my friend Congresswoman Doris Matsui that would authorize a health IT demonstration for behavioral health providers. Do you think electronic health records can play a role in states' efforts to combat the opioid crisis, and how is it the state of Vermont is using electronic health records?
The simple answer is yes.
No, the simple answer is that's brilliant. So we don't, so I'm a restaurant owner, got into this, sort of later in life. He was a construction company owner, and we thought we were behind the 8 ball in terms of being modern until we really got to work in healthcare. I mean, I haven't seen a fax machine or a typewriter in a long time, but you can find them in some behavioral health clinics and some doctor's offices. So the point you're making is right on target. There is not the electronic systems that are necessary to run our community mental health agencies and the like at the level that most people would think they would have. FQHCs as well, et cetera.
I would like to offer as well, and when we talk about some of the centers for treatment centers in our rural areas, it does put a burden on many who are seeking treatment. And when you think about in some of our rural sections, we had a waiting list in one area of 700 waiting for treatment. And that doesn't lend itself well for those seeking treatment when they have to be put on a waiting list. As well, those who were in treatment at that time, it was so far away that they would spend 2 hours driving to or taking a bus going to a treatment center to receive their treatment on a daily basis. 2 hours one way, and then 2 hours back, an hour's worth of treatment. So for those who were expecting to reintegrate into the workforce and be part of society again, it doesn't lend itself well when you're trying to take care of your family and to find a job where it's flexible enough so you can receive treatment. So it's something, we did put a hub in that area. We reduced that level from 700 to 0. We don't have a waiting list in that area anymore, and that's successful. I mean, that was a time when we took a moment to celebrate success, because you don't have much success on some months. But that was a time when we said we're doing something fruitful and in a positive way.
Thank you. Ms. Sewell.
I want to thank the chairman and ranking member for hosting today's forum. As many of us have seen, more Americans died from drug overdoses in 2016 than the number of those lost in the entirety of the Vietnam War. And preliminary data from CDC suggests that 2017 was even worse than 2016. I want to thank you, Governor Scott, for your leadership on this topic, as well as your testimony today. It is my hope that more states, including my own state of Alabama, will realize the successes achieved in Vermont and implement similar strategies to tackle this growing epidemic. You spoke a little to your administration's focus on the importance of helping people in recovery return to gainful employment. I, like you, Governor Scott, have met with many people who are in recovery who tell me that it's the dignity of a job that keeps them going and that keeps their families going as well. So I think it's really important that we have models that stress the importance of getting gainful employment, even when you're still in treatment, as you suggested earlier. The way we address this public health crisis will serve as a model for decades to come on addiction treatment. I believe we made a terrible mistake in the 1980s as a country in our response to the crack cocaine epidemic, where we're seeing that the response we gave was for more jails and not for more treatment centers. I am very happy that with this epidemic, we are seeing that it truly is a public health crisis, and it's a crisis that requires intergovernmental help and lots of wraparound services. And so figuring out how we can get best practices, I think, is really important. An issue I worked a lot with in my rural areas is transportation. And so often getting access to treatments has been a big problem in the state of Alabama. In fact, I introduced a bill with Congressman Meehan. It's a bipartisan legislation that would allow Medicare Advantage plans to offer a wider array of supplemental benefits to chronically ill enrollees, such as transportation and nutrition programs and mental health services. I believe we should implement this type of benefit expansion across Medicare programs. So I guess my question to you is, Governor Scott, would you recommend expanding coverage for treatment in Medicare? And can you explain why you believe improved Medicare treatment for coverage for treatment of opioid is important in fighting this epidemic?
Yeah, absolutely. I'm going to let our secretary answer, fill in the gaps, but I did want to mention that's what the beauty is of this hub and spoke model, that we can have treatment facilities closer to those who need it. And when we see an area, such as we did, that needed more treatment, we set up another hub. So it's essential that we react every time that we see an issue. I would also say with the introduction and the use of Narcan in our state, I'm afraid that the number of deaths that we're seeing, which is almost the same as the previous year, doesn't tell the whole story, because we're preventing a lot of deaths from happening. So that doesn't mean that just because they're staying the same doesn't mean that we're necessarily making a lot of ground up. So we have to fulfill that. Stigma is an important part of reintegrating, again, those into the workforce. And I think we've made some positive gains in that respect. A lot of employers we are speaking with, we're making a concerted effort through our Labor Department to try and determine, give those folks a second chance, or third chance, or fourth chance, because sometimes it's not the first time or the second time, it's the third time. I had employees of mine that we all are aware, more aware now than we were then, that were addicted, and I didn't know it. And they were great employees. And so we gave them that chance, that opportunity to succeed.
Thank you.
Mr. Marchant.
Thank you, Mr. Chairman. Governor, you're out of you've spent some time in the legislative branch. Do you think that your state has passed sufficient laws, statutes to give you the tools that you need to combat this? I've got three questions. I'll ask all three of them. Secondly, who recognizes in Vermont this dependency? Is it the state? Is it the doctor? Is it a person themselves that recognizes they're addicted, or is there a definition that the state has? And the last thing is most of the acquisition of the opioid legal or illegal?
What was, sorry, sir?
The acquisition, getting the pills. I mean, are they getting the pills legally, or are they buying them on the black market or from a dealer as a percentage of the people that are
I'll try and answer some of those, and again, I would ask my secretary to fill the gaps in. But what we're seeing is a lot of the crime rate is due to obtaining some of the prescription drugs even, and some of the unused prescription drugs in medicine cabinets. That's why the Take Back program is so necessary. Those who have been utilizing opioids, their kids get involved, they take the drugs, they sell them or utilize them themselves. That's an issue. I'm trying to recall the rest of your question.
As your legislature passed the statutes that you need?
Yeah, continually. I think we have a good working relationship. Again, I've served in the minority, but we've always worked together, trying to do whatever we can because we recognize this isn't a partisan issue. This is an issue that faces each and every one of us. It doesn't discriminate. Whether you're Republican or Democrat, it doesn't discriminate. It doesn't discriminate from a social standpoint or either. So we recognize that, and we've been given many of the tools, and we continually seek resolutions to try and obtain more. Okay.
And I think the last question you asked is, what door do you walk through to get treatment in Vermont? And we try to...
Who declares that you need treatment? Is it usually self-declared, or is it...
So what I would say is that for treatment to work, it pretty much has to be self-declared, meaning on a base level, it has to be a recognition that the person has to make. But also, through the screening tool that the governor talked about in his opening remarks that we use in primary care offices, in emergency rooms, and in other healthcare delivery sites in our state, it allows for the conversation to happen with your healthcare provider or a healthcare provider where you may become aware of your behavior to help you get there. But also our hub and spoke model, the hub is actually not just a hub for treatment, it's a hub of activity where you can go and receive counseling on your addiction and your options. We also have recovery centers in the state where you can go and basically reach out and get peer support for recovery. So we have a lot of different doors you can open. We're in the position now of how do we get more people into treatment, because now we can meet the needs of treatment. The governor articulately went through our waiting list. We just recently, in the last 6 months, have gotten to the point where we've eliminated the waiting list. So now we're trying to figure out how to get more people into treatment.
Mr. Blumenauer.
Thank you. Thank you very much for joining us. I appreciate your efforts to kind of put a comprehensive picture on the table for us, and I think each and every one of us on an ongoing basis is struck by how complex and interdependent these elements are in our own community. We're troubled with addiction, homelessness, mental illness, nothing rising probably to the level in terms of the death and destruction of opioids, but there are a whole series of interrelated pieces. And there's lots of blame to go around. The federal government was asleep at the switch, problems with the pharmaceutical industry, with the medical profession. And I appreciate your taking us through your outline of what we could be doing. I was particularly struck by your fourth point. Your small state could benefit tremendously from nationally supported research for areas of alternative treatment for pain. People are driven to opioids often when there are, in fact, cheaper and more effective alternatives, starting with therapy. But I would also point out one that my state has been a pioneer, and that happens to be medical marijuana. There's pretty strong evidence that where medical marijuana is available, there are fewer opioid deaths. I think in the state of California, it's a third less than the national average. And I have had countless people, veterans, tell me what difference it made for them to be able to have an alternative that was cheaper, less toxic, they felt more comfortable with. NFL players are suspended routinely, maybe not the wife beaters, but the people who are caught self-medicating with pot because they don't want to get shot up with painkillers, in some cases leading to tragic consequences. I'm hopeful that this might be an area that we can explore. You just became the first state to have the legislature approve adult use of marijuana, something every other state in the union, 30 states, have done it by a vote of the people who've been ahead of the politicians on this. And I wonder if you have some thoughts about opportunities to use medical marijuana as an area to expand these treatment options, to be able to properly research it, to get rid of the federal prohibition on robust medical marijuana research, and be able to explore this as an alternative to this plague.
We passed medical marijuana when I was in the Senate, and I voted in favor, one of the few Republicans that did. I was serving with Congressman Welch at the time. We recognize that one size doesn't fit all, that's why we need as much flexibility as possible, all different types of treatment on the table, so to speak, so that we have everything in our power to confront this. My wife is an RN. She lives this on a daily basis. She sees it in the office on a daily basis, all the abuse in terms of prescription drugs. But my wife as well is a runner, an athlete, and she's had a number of knee surgeries, thought her running was over, and she started using this oil therapy about a year and a half ago. And she's back to running. She did a 10-miler about 2 months ago. So this worked for her. What my point is, we just need everything on the table. We can't allow ourselves to be put blinders on in terms of what might work for one that might not work for another.
Ms. Black, another RN.
Yes, and thank you, Mr. Chairman, and to your wife, who is an RN and a runner, and I too. So I applaud you for tackling this issue that is a very large issue. And I want to go to the side, as you would expect an RN to do, and that is, how can we stop this from happening to begin with? Because the cost of life, the cost of treatment, the cost of the illegal activity is certainly very, very large. And so I'm very interested in what you said in your opening statements about the prevention piece of it and how your state is using the prescription monitoring system to help physicians. However, I do see in here later on you say that for the first time we're beginning to see the amount of opioid prescriptions decline. It's discouraging to note, however, that we still prescribe 3 times as much as you did in 1999. So a little bit of a contrast there about we've got a system where we can see what's going on, and yet there still seems to be more of this being prescribed. Can you help me out with that?
Well, again, in 1999, it skyrocketed after that. There was just much more opioid prescription use. So we have seen, since we implemented that policy, we've seen it go down significantly. But still, compared to 1999, we're still using 3 times as much.
Is this real time for your physicians, that they can get into a computer and see whether someone has gotten a prescription filled, and this is real time?
Yeah, I believe it is, yes.
Okay,
go ahead.
so that's very helpful.
It is real time.
Okay. Let me go to the second piece, is the early intervention. Again, the prevention piece, the screening, the brief intervention, referral to the treatment protocol. All of those things that are done in the emergency rooms, primary care. Is this someone coming in that's self-referred, or is this when they come in for other kinds of treatment that the practitioner would say, that maybe this is something I need to address and talk about? How is that actually done?
I think it's all the above, actually. It could be from many different situations to at least make others aware of the situation.
Yeah, so the way we did this was we received a grant and some federal money to be able to do this in one hospital. And we started there, and we've kind of spread out. And we don't do it everywhere in the state yet, but we do it across a large part of the majority of the state. And it isn't just if you come in saying you think you have an issue with addiction or substance use disorder. It's literally if you come in for something else, we begin a screening process that sort of that begins the conversation, and depending on how you answer questions and and interactions, we go further and further and further.
So you do the screening process on every patient that comes in, they answer a screen, and then from there you make a determination.
Right.
Okay, okay. Let's see, I have one additional question. Oh, so in many other states we see doctor shopping. Have you seen that in your state? Do you have pill mills? Do you see that doctor shopping? And do you also have those facilities that are pain management that are for cash only? Are you experiencing that in your state? So pain clinics that really turn out to be pill mills and just a front for someone getting a
I don't think we see the pill mills in Vermont, but certainly we see the doctor shopping, and some of this electronic monitoring would help preclude that.
Yeah, so what's interesting is we don't have what you think of as the traditional pill mill, but we certainly had the issues you're describing. Doing the spokes and having over 200 primary care providers working together to try to basically deal with treatment, it has been really good for communication across the practice, and so it's cut down on doctor shopping. But also our prescription monitoring system has improved every year, and it's at the point now where doctors can see that going on through software.
Thank you. My time's expired. Thank you, Mr. Chairman.
But keep in mind as well, if I could just add.
Wow, sliding into home. Nice.
Keep in mind that if you shut someone off from the prescription drug, the opioid, they find another method. They go to heroin or fentanyl. I mean, it's cheaper sometimes, so that's the problem.
Mr. Higgins.
Thank you, Mr. Chairman, and congratulations as well on your ascension as the subcommittee chair. My community, too, is devastated by this opioid deaths and overdoses. There were 316 in Erie County in New York State. Half of those were in the city of Buffalo. I just want to focus in on fentanyl. Fentanyl is it's a powerful artificial opioid, and it accounted for about 60% of the deaths in my community of Buffalo and in Erie County. Mexico is the source of much of the illicit fentanyl that is for sale in the United States. Starting in 2015, Canada has seen a massive increase in fentanyl overdoses. You know, we're currently engaged in a renegotiation of the North American Free Trade Agreement. And I have always believed that the United States and Canada, the United States, a nation of 323 million people, Canada, a nation of 36 million people, doesn't effectively use its leverage in trade negotiations with a place like Mexico. You know, Mexico's minimum wage is $4.70, not an hour a day, which if you assume it's an 8-hour day, it's 57 cents an hour. In free trade, we should be using our leverage to stop this illicit export of fentanyl to the United States and Canada. It's a new twist on a larger problem. Just curious as to your thoughts about the viability of something like that.
Well, again, we watch with interest the NAFTA negotiation. We share as well a border with Canada, and they're our largest trading partner, essential to the vitality of Vermont's economy. So we're hopeful that we can get through some of those, but I think that there should be an update to NAFTA, and I believe that we should be trying to do whatever we can to level the playing field, and that may be an area that we should look at.
The President in October declared that the opioid epidemic was a national health emergency. As you know, we've been kind of stuck in terms of doing a series of continuing resolutions, which is really a failure to do fundamentally what Congress needs to do. But obviously money is a big issue here as it relates to treatment. Have you seen any change at least in terms of your personal experiences since that declaration was made in October? Or is that something perspective that just hasn't gained traction yet?
I don't believe that we have seen any difference since that declaration because we have been actively pursuing that. And we've been blessed with having good partners, again, with the Congress as well as with the administration and this previous administration as well, in trying to confront this. So they've given us some flexibility, and I think that that's been essential. And if there's one thing that I can underscore and emphasize is allow us flexibility, and we'll find the pathway forward.
I yield back, Mr. Chairman. Thank you.
Thank you. Well, Governor, thank you. And Mr. Secretary, thank you. Just want to say thank you very much for your time today. We're called in for votes. Let me ask you one sort of, just kind of a little bit of a wrap-up question, if I could. Our subcommittee, and this committee in particular, is focused in on Medicare. And one of your original, or the first point that you made in your 4 points was in particular as it relates to Medicare. Let me just restate that, just to refresh everybody's recollection. And then I just want to just give us a little bit of commentary about what this means. So what you proposed is Medicare needs to treat addiction as the chronic health condition that it is. And then you said you sent a letter to the Secretary of Health and Human Services asking that CMS work with Vermont to engage Medicare in Vermont's system of care, specifically the hub and spoke system. Working with our federal partners, we hope to develop a path to make this a reality. Medicare could also assure that the FDA-approved medications for opioid addiction are available for beneficiaries. I want to sort of go back to Mr. Marchant's inquiry from Mr. Marchant from Texas when he was asking about sort of the declaration of who is addicted. Can you just give us a little bit more insight? So is this a situation where in order for this to be successful at all, someone has to self-identify as an addict? Or does the hub and spoke system work for folks that are not acknowledging that are addicts, but who are clearly addicts? Can you speak to that tension? Maybe it's a question for the Secretary or the medical professionals.
To let him answer the rest of the question, so to speak. But I would, again, underscore that if they're not ready to admit that they have an issue and to seek treatment, it's probably going to fail. Mm-hmm. And so to force someone into treatment is probably a recipe for failure as well. Secretary?
Yeah, so what I would say is there is a definition of opioid use disorder, and they would have to meet that clinical definition. And so that's sort of the black and white answer. But I think from a human perspective, when you think about caring for the whole patient or the whole population, to have something that is such a fundamental problem with someone's health and not be able to treat it as basically the illness that it is with the payer that they have sort of distorts the healthcare system. And so what we're trying to do is work with CMMI and CMS to say we have an all-payer model that we've agreed to with the federal government to really take responsibility for what we spend on healthcare. And in order to do that, you have to treat the whole person and the whole population. And this needs to be an integral part of that.
And if you want to break down the stigma, this is one way to do it, to treat them the same.
Well, your insights have been really helpful today, and you didn't clear the room, by the way. You didn't clear the dais. It was the fact that we've been called for a vote. But I just want to let you know how much I appreciate, and I know I speak on behalf of the ranking member as well. We appreciate your willingness to come and share your experience. We appreciate your forthrightness with the strengths and weaknesses, the things that you've learned, the things that you've struggled with, and I know that we're going to continue to be interacting on this because this is an issue that is very dear to all of us, and I mean literally all of us, and it is an area where there's good work that can be done, and I think people of goodwill and tenacity and willing to give others the benefit of the doubt as we move forward can be really, really significant. So I sense you've got something else to say, Governor, so why don't you bring
only
us home.
that we extend an invitation to anyone on your subcommittee who would like to come up and see it for themselves. We would happily show them what we've done.
Thank you.
so that you can see it.
So the committee stands in recess subject to the call of the chair. We're going to go into recess and vote, and we'll look forward to hearing from our next panel. So thank you very much.
Thank
We'll
you.
be back shortly.
Thank you.
Yeah, I really appreciate your time. Really do. Very much. It was good insight. Come up and see us. I will. I will. Yeah, thanks, Secretary. All right. All right. We'll be all over you. Can you send me a copy of your letter? Yes. That'd be helpful in terms of framing this issue. All right. Walsh does a nice job. He's a good guy.
And Matt White, she does some great work. I send money every year because I think it's just frugal enough, so I think that's a great approach. Yeah, they done good work.
Yeah, we're going back. Oh my God, that's a quick trip. Thank you for coming. We had a number of folks recommend that we have you all come to the hearing, so this is really wonderful. Thank you.
We'll see if they ever.
Your staff was good.
Yeah, no.
You guys were great.
Have a good day.
Thank you. We appreciate it. Have a safe trip back.
Absolutely.
The committee will come to order. Thank you all. I know I speak on behalf of everybody who's reassembling here, and thank you for your patience. As I mentioned, your opening statements are a part of the record, and the members have had an opportunity to review them. I think in the interest of time, why don't we begin to proceed? I'll recognize each of you for 5 minutes, and we'll give you a little bit of guidance in terms of the timing, and then we'll open it up for questions from our members. So again, thank you for your patience. We really, really appreciate it. Dr. Benjamin, you're recognized for 5 minutes.
Chairman Roscom, Ranking Member Levin, and distinguished members of the committee. Thank you for the opportunity to provide my views on behalf of American Society of Interventional Pain Physicians, known as ACIP. I'm Dr. Ramsin Benyamin, and I'm the Medical Director of Millennium Pain Center in Illinois. I've been practicing interventional pain management for over 20 years. My academic appointments are with the University of Illinois, Illinois Wesleyan University, and A.T. Still University of Missouri. I serve on the editorial board of several pain management peer-reviewed journals and have over 150 publications, the most recent of which is our Society's 2017 Guidelines for Responsible, Safe, and Effective Prescription of Opioids. In the past, I've served as the president of ACIP, and I'm currently on the board of directors. I'm also the president of Illinois Society of Interventional Pain Physicians. ACIP is a non-for-profit professional organization founded in 1998, now comprising of over 4,500 members who are dedicated to ensuring safe and appropriate access to pain management services using interventional techniques in addition to medical management. As an organization, ACIP has always been cognizant of prescription opioid dangers and began issuing warnings and offering preventive measures in early 2000 with its proposal of a national program known as NASPR, which eventually was signed into law as a state-run prescription drug monitoring program in 2005. Despite challenges in implementation of the national program, all 50 states now have prescription drug monitoring programs. Many of the common painful ailments like spine degeneration, disc herniations, spinal stenosis, headache, pathologic fractures, and post-surgical chronic pain, if not managed timely by interventional pain techniques, will result in more invasive and costly procedures, raising the risk of dependency on more or higher doses of opioids. Currently, 1 in every 3 Medicare Part D recipient is on prescription opioids. Based on current data, despite reduction in opioid prescriptions since 2010, the majority of overdose deaths are mainly due to synthetic fentanyl and heroin abuse. Mr. Chairman, the pill-to-heroin shift has occurred, and that also involves lacing of marijuana with heroin or fentanyl. That's killing many of my fellow citizens in Illinois. As a result of this disturbing trend, on behalf of ACIP, I'm suggesting legislative reforms to curb opioid abuse and reduce opioid deaths, while maintaining appropriate access and promoting non-opioid modalities like interventional techniques. Unfortunately, reductions and cuts continue to limit access to physical therapy, interventional techniques, and even non-opioid medical therapies, while the opioid death rate continues to escalate. Our proposal includes a 3-tier approach. Tier 1, an aggressive public education campaign focused on the dangers of illicit drugs, specifically heroin and fentanyl. A public education campaign relating to the adverse consequences of prescription opioid abuse, particularly in combination with benzodiazepines. Mandatory 4 hours of continuing education for all prescribers of any amount of opioids or benzodiazepines. Tier 2, improved access to non-opioid techniques, including physical therapy and interventional techniques, by lowering or eliminating co-payments. Expanded low-threshold access to buprenorphine for opioid use disorder treatment. Enhanced prescription drug monitoring program, including a national program like NASPR, with states having mandated capability to interact with the rest of the states, or at least the neighboring states. Mandated review of prescription drug monitoring data by all prescribers prior to prescribing a controlled substance. Tier 3, buprenorphine must be available for chronic pain management with rescheduling it to a Schedule II. And remove methadone from formulary. This medication, despite being only 1% of total prescription opioids, it results in more than 3,000 deaths every year. Thank you again for allowing our organization the opportunity to testify. I'll be glad to answer any questions.
Thank you. Mr. Kletter.
Chairman Roscom, Ranking Member Levin, and members of the subcommittee. I appreciate the opportunity to testify today about the opioid epidemic that is ravaging our country and important steps this committee can take to help address this crisis. I'm Dr. Jason Kletter, President of Baymark Health Services. Baymark provides treatment for opioid use disorder, or OUD, using medication-assisted treatment and outpatient detoxification services in 95 facilities across 26 states, including many of the states you represent. We're the largest organization in the country focused primarily on treatment services for opioid use disorder, treating over 33,000 patients each day. I also serve on the board of the American Association for the Treatment of Opioid Dependence, and I'm also here today on behalf of the OTP Consortium, a trade association comprised of more than 300 opioid treatment programs across 37 states. I have 25 years of experience in OUD treatment. I want to start by highlighting 2 data points. First, according to the CDC, opioids killed more than 42,000 people in 2016. That's about 115 people every day in our country. These are our friends, our family, our neighbors, our coworkers. Second, the White House Council of Economic Advisors estimates the economic cost of the opioid crisis was $504 billion in 2015 alone. Of course, these statistics do nothing to describe the devastating effects on our families and communities. OUD is regarded by experts to be a disease of the brain, not a moral downfall. This concept of OUD as a chronic disease is essential to understanding successful treatment solutions, the most effective of which is medication-assisted treatment. MAT is the integration of medication and psychosocial services to provide individualized care that will have the greatest likelihood of helping people with OUD transition to recovery and lead healthy, socially productive lives. There are 3 federally approved medications for use as part of MAT: methadone, buprenorphine, and naltrexone, all of which must be used in conjunction with psychosocial services to have the greatest likelihood of success. The benefits of MAT are substantial and have been proven repeatedly through rigorous scientific studies. MAT has been shown to improve patient survival, increase retention in treatment, decrease opioid use and criminal activity, increase patients' ability to gain and maintain employment, and lower a person's risk of contracting HIV or hepatitis C. Those who receive MAT are 75% less likely to have an addiction-related death than those who don't. There are roughly 1,500 opiate treatment programs, or OTPs, across the United States, providing treatment to approximately 400,000 patients. OTPs are highly regulated, comprehensive treatment programs that are required by law to provide MAT. OTPs provide medication, individual and group counseling, random drug testing, and other supportive services such as case management, primary care, mental health services, HIV, and hepatitis C testing. Methadone, which is most commonly administered as part of MAT, has been used in OTPs for more than 50 years. It has been rigorously researched and considered to be the gold standard in treatment of opioid dependence. MAT with methadone is highly regulated and can only be dispensed for OUD by clinics that have been certified by SAMHSA, the DEA, and other agencies. It is an excellent medication when used as part of MAT, with patients having very high retention and success rates. Retention in treatment over an extended period of time is essential for positive outcomes. At Baymark, about 61% of our patients are retained in treatment for at least 90 days. Furthermore, while 100% of our patients are using opioids multiple times each day upon admission, about 50% of those folks in treatment less than 30 days are free from illicit opioids. That number jumps to 82% for patients in treatment more than 1 year. This is proof that MAT delivered in OTPs is saving hundreds of thousands of lives. According to CMS, 30% of Part D enrollees used prescription opioids in 2015. So we should not be surprised that more than 300,000 Medicare beneficiaries have been diagnosed with opioid use disorder. Moreover, Medicare beneficiaries have the highest and fastest growing rate of OUD. Unfortunately, Medicare does not cover comprehensive treatment services and OTPs. Instead, Medicare pays for more expensive treatments in less effective settings. This must change. We respectfully request that Congress pass legislation to provide Medicare beneficiaries with coverage for MAT with all FDA-approved medications to help treat OUD in the OTP setting. We recommend that Medicare adopt a bundled payment methodology where MAT-related services provided in the OTP setting are reimbursed under a capitated rate. This model has proven to be successful in Medicaid and TRICARE and could be quickly implemented by the 1,500 OTPs across the country, rapidly increasing access to life-saving treatment for Medicare beneficiaries. While our country is in the throes of a tragic epidemic, the silver lining here is that we have a very effective treatment and a dedicated and compassionate workforce ready and able to save lives and build communities. Thank you for the opportunity to testify today. I'm happy to answer any questions that you have.
Thank you very much. Dr. Paz.
Thank you, Chairman Roscom, Ranking Member Levin, and members of the subcommittee for holding today's hearing on the opioid abuse epidemic. I appreciate the opportunity to share Aetna's perspective on this critical public health issue. Aetna is a leading diversified health company that serves over 38 million individuals in the United States and around the world. I currently serve as the company's Executive Vice President and Chief Medical Officer, a role I have held since 2014. In my capacity as CMO, I lead clinical strategy and policy across Aetna's lines of business and am responsible for driving clinical innovation to improve member experience, quality, and cost. I am also a practicing physician. The opioid epidemic is the leading public health issue facing our nation. We've already lost far too many of our friends, family, and neighbors to this unprecedented health crisis. Aetna is taking a holistic approach to addressing the opioid epidemic. The various segments of Aetna's businesses are all working to help our members struggling with addiction and to prevent future opioid dependency. To that end, Aetna has created an enterprise-wide opioid task force, which I chair, to drive a multifaceted strategy to help stem the tide of overuse. We've developed a strategy focused on preventing misuse and abuse, intervening when we identify at-risk provider and member behavior, and supporting members by providing access to evidence-based treatments. I'm pleased to share with the subcommittee 3 examples of Aetna's efforts to fight the opioid epidemic, as well as recommendations for Congress and the administration. We believe important efforts in our commercial lines of business can inform how CMS regulates Medicare Advantage and Part D plans to allow for similar programs in the Medicare space. First, within our commercial business, Aetna is leveraging formulary and plan design tools such as quantity limits and prior authorization to reduce opioid misuse and encourage evidence-based treatments. For example, as of January 1st, Aetna is limiting initial opioid prescriptions for acute pain to a 7-day supply. These stricter daily and dosage limits are in alignment with CDC guidelines and will help reduce the potential for abuse and addiction. Second, effective January 1st, Aetna became the first and only national payer to waive co-pays for Narcan, a life-saving, highly effective opioid overdose reversal agent, for our fully insured commercial members once their deductible is met. We hope that this copay waiver will increase access and remove possible financial barriers to the use of naloxone. Third, within Aetna's Medicare business, we are striving to be part of the solution. Aetna has taken steps to promote appropriate prescribing and coordination of care for our Medicare members who utilize opioid drug therapies. Aetna has instituted interventions in its Medicare formularies to assist members in receiving appropriate opioid medication when necessary while preventing inappropriate use and addiction. We also support pharmacists in utilizing opioid controls as well. Aetna is committed to continuing to work with CMS to highlight areas of opportunity for change to better combat the opioid epidemic. We believe there are 3 specific areas where Congress and CMS can take additional steps to help remove barriers currently limiting the ability of plans to combat the epidemic itself. First, while Aetna now limits initial fills of acute opioid prescriptions to a 7-day supply in our commercial business, Medicare Advantage and Part D plans are precluded from unilaterally limiting the duration of a prescription. We are encouraged that CMS, in its recently released call letter, is proposing significant steps to allow Medicare and Part D plans to take more action to preventing overprescribing. We strongly encourage CMS to finalize provisions that allow additional point-of-sale edits and supply limits of prescription opioids that limit initial prescribing to a 7-day supply. Second, we also support CMS's continued efforts to address the opioid epidemic and believe the implementation of CARA and the adoption in Part D of a lock-in mechanism will provide sponsors with a critical tool to help curtail the abuse of opioids. Still, we believe there are several changes CMS should make in implementing the lock-in program to ensure its success, such as allowing Part D sponsors to retain the ability to use point-of-sale claim edits to address other frequently abused drugs, and allowing plans to maintain the lock-in status of a member until notified by the applicable provider that the member is no longer at risk. And finally, we strongly support modernizing privacy regulations to provide access to a patient's entire medical record, including substance use disorder records, and to ensure that providers and organizations have all the necessary information to provide safe, effective, high-quality treatment and care. We urge Congress to expeditiously pass the bipartisan legislation introduced in the Senate and here in the House by Representatives Mullen and Blumenauer to align this outdated regulation with already strict HIPAA standards. In conclusion, Aetna is deeply committed to doing its part to turn the tide on the epidemic. We look forward to continuing to play a productive role in the dialogue with the subcommittee and with other policymakers to help find solutions to this epidemic. Thank you again for your leadership on this issue and for inviting Aetna to be here today.
Thank you very much. Ms. Hungeville?
Mr. Chairman, Ranking Member Levin, members of the committee, I am Laura Hungeville, Chief Pharmacy Officer for WellCare Health Plans. I want to thank you for your invitation to appear today to share with you our experiences regarding the opioid epidemic and the variety of practice we have employed aimed at curbing the overuse and misuse of prescription opiates. It is important that the committee is addressing this vital issue, and managed healthcare companies are equally committed to finding solutions. First, though, let me tell you a little bit about WellCare. Headquartered in Tampa, Florida, WellCare focuses exclusively on provider government-sponsored managed healthcare services through Medicaid, Medicare Advantage, and Medicare prescription drug plans. WellCare prides itself on managing healthcare services for the underserved and most vulnerable populations. We serve 4.3 million members nationwide, with roughly 1 million members relying on WellCare for prescription drug services. In any given state, our beneficiary population ranges from 40 to 50% dual eligible. Well, certainly not the only population at high risk of controlled substance misuse. Mental illness and poverty often go hand in hand with substance abuse disorders. We have spent the last several years investing resources and time into innovative methods for decreasing the misuse of controlled substances among our beneficiaries, culminating most recently in the launch of an opioid task force. This task force was created to ensure that we are taking an integrated approach to helping our members. Our company has insourced medical, pharmacy, and behavioral departments, a rarity among managed care plans, to ensure that we are looking at the member in a holistic manner. Our first and foremost, our goal is to prevent abuse and addiction. Our second goal is to help our members who are battling addiction and often chronic pain, to help them manage both conditions. Those members who are at the greatest risk of overdose and death receive the highest attention. One of our key programs involves monitoring doctor and pharmacy shopping so we can flag high utilizers. WellCare works with patients to enter into medical service agreements, which patients benefit from having a single doctor focused on prolonged pain management therapies to deter opioid misuse. For several years, WellCare's pharmacy-run opioid overutilization case management program has been using predictive modeling to identify at-risk individuals. As a result, WellCare proactively identified over 200 at-risk members nationally in 2017 based on specific criteria including prescription dispensing, provider, and emergency department utilization. We placed these individuals into a lock-in program connected to one pharmacy, one healthcare provider, and a care manager who helped connects members to needed physical, behavioral, pharmacy, and social services. In regard to the CMS standard for morphine equivalent dosage, we have also identified 2,100 additional members who have received prescriptions over the previous CMS standard of 120 milligrams of opioids per day. We intervene with these members through member education on alternative medications, outreach to prescribers, and have begun including integration point with our behavioral health case management team. For our non-cancer members, this translated into utilization reduction of over 43% between 2015 and 2017. Since the transition to the lower daily ceiling of 90 milligrams of morphine equivalent doses, WellCare continues to see increased numbers of members captured through our overutilization case management program. We also recognize that we must look beyond the treatment of pain to address opioid overuse. Our multifaceted set of interventions includes the creation of the CDC-compliant task force and engaging policy groups at the state level to include prescription drug monitoring program training, CME for physicians on the training of using opiates. Some of these partnerships also include working with the YMCA to educate teens on the risk of opioid use, especially in the foster care system. At the organizational level, we are rolling out telehealth programs for use in emergency rooms to help increase medication-assisted treatment. And finally, we're also developing incentive programs for physicians to become SAMHSA certified, given the increased demand for addiction specialists, much of which I have outlined have been possible because of states like Kentucky, where Medicaid regulations allowed us to be aggressive in targeting opioid misuse. And in Kentucky, we were able to see a decrease of nearly 50%. We'd also like to recommend CMS incentivize other providers to become SAMHSA certified, allow health plans to be empowered to have more restrictive lock-in programs, mandate electronic prescribing of opioids, and address the gaps that create barriers for plans by providing PDP plans with access to medical claims, and allow health plans access to PDMPs as well. Lastly, Congress, CMS, and the FDA should create educational campaigns similar to one deployed for tobacco cessation to educate consumers about the dangers of opioids and remove the stigmatization and encourage people to seek help. In conclusion, ending this opioid crisis will require a partnership with all stakeholders, and WellCare looks forward to being an active participant as the committee and Congress work to combat this epidemic. Thank you.
Thank you very much. You've given us great insight and very valuable perspectives. We're in a very uncertain time right now in terms of scheduling and sort of the chatter that we're getting about being called back in. So, and the fact that this has been a two-panel hearing today, I'd ask unanimous consent to limit the members' questions to 3 minutes, and without objection, so ordered. And with that, we'll yield to recognize Mr. Kelly.
Thank you, Chairman. Thank you all for being here. Dr. Benyamin, I was fascinated by your testimony, and I think last year when President Trump talked about this war on drugs, he had talked about non-addictive painkillers. Because we are a nation now of dependence or codependence, I don't think there's any doubt about that. If you could just go a little bit longer into that, I marvel at the fact that we have 50 laboratories around this country that are doing all this type of data and collecting data. But your testimony, more than anything, appealed to me because I've been so close to this issue. Would you expand a little bit more on the fact that we do have a way of keeping pain down, but I think the development of those drugs was really had to do also with reimbursements, right? If we can keep the pain down and the patient says, I'm not feeling the pain, it's a better result, but it involves an addiction. So please hit the non-addictive ways of getting to killing pain.
Thank you, Congressman. Very good question. We can divide that into two sections, the medication part and the interventional part. So on the medication front, we have had challenges as far as funding and research funding for non-addictive medication, as you know. And we do not have many choices. Our choices are between scheduled prescription drugs and anti-inflammatories. And we all know that anti-inflammatories have their own side effects. One of the issues there is access. Many of the health plans do not cover non-opioid medications. Like, I'll give you a good example of a patch that is anti-inflammatory. If you call for a pre-authorization, they all will deny the patch. They will say to you, well, we do not cover anti-inflammatory patch, but we do cover a fentanyl patch. That's the answer that you get. So that tells you part of the problem that we face. On the non-medication front, I think we are a young specialty, interventional pain management is a young specialty, and we have been adding to our tools to treat, as I mentioned, the spinal disorders like spinal stenosis and fractures in the spine. These are conditions that in the past we did not have any solution between surgery and opioids. And now we are providing solutions that are minimally invasive techniques that can prevent these patients from getting to the point of becoming dependent on opioid or having all these invasive surgeries and as a result become dependent on opioids.
Listen, I want to thank you. I'm running out of time. I want to thank you all for being here. We've run out of options as a country. We have to get this fixed. So thank you so much for what you're doing. Please continue your work. We really appreciate you being here. Thanks so much. I yield back, Chairman.
Mr. Levin.
Well, I join in our appreciation for all of your efforts. Just quickly, and then I wanted to ask you another question. Why do you think it took us so long to recognize this epidemic? Anybody want to venture? It did take us a long time.
Can I take a
Please.
shot at that? So I think part of it is a lack of awareness and lack of knowledge, lack of public information, and usually we react. You know, we always react we go from one extreme to the other. As I said before, this is not just a pill problem anymore. The shift has occurred from the pill to heroin and synthetic fentanyl. And we are, I mean, I'll be glad if we take some precautionary legislations that will prevent that from happening and reduce the supply of these drugs in our country. My community, the rate of death from opioid overdose had tripled in 3 years. And you know, it's kind of hard. I would like you to understand that it's very hard for the coroner to determine the exact cause of death. You know, all these data are based on coroner's report, which is based on what pathologist finds in the system. Now, if you have 5, 6, 7 medications or drugs in the system, who is to say which one of these is the real cause of death? That's why they mark them all as opioid overdose.
So let me ask you then, in terms of awareness, expanding Medicare treatment, isn't that a very good idea? Doctor?
So if I could add to that, I think to your first question, the reason it's taken so long to recognize is less about not recognizing it, more about the stigma associated with the disease. People with the disease of addiction are sort of shunned and kept in the shadows and embarrassed and shamed. And treatment has been sort of similarly treated. There hasn't been a lot of attention or focus on treatment services. In fact, physicians are not taught how to treat addiction in medical school generally. They're not taught a lot about opiates.
So expanding Medicare.
So how can expanding Medicare help? Well, first of all, making it part of mainstream medicine, helping to sort of acknowledge the disease as just that, as a disease. We heard the Governor, Scott of Vermont, earlier say we need to do a better job of acknowledging the disease and thinking of it as a disease rather than thinking of it as a lack of willpower or a moral downfall.
Okay,
and
well,
so Medicare contributes to that by legitimizing the treatment that we have as a medical treatment.
Thank you.
Mr. Paulson.
Thank you, Mr. Chairman. I want to follow up a little bit on some of the perspectives that were offered, the minimally invasive procedures. And look, I mean, historically, the practices of providers have been to prescribe opioids to patients for years, and it's hard to stray away from that course and then try new different therapies for pain management. Now, I also understand there are about 200 FDA-approved devices for which CMS does reimburse, but it seems that not enough providers or Medicare Advantage plans, for instance, are alerting patients to some very effective and efficient ways to manage pain outside of for the risk of addiction. One example is a spinal cord stimulator that involves a minimally invasive procedure, uses electrical signals to block pain signals from reaching the person's brain, has about a 50% or greater opportunity for reduction in pain, and more than half of the patients, then they don't need to have any pain medication for that management. And it's FDA approved, it's Medicare reimbursed, it's helped about 500,000 patients. So I'm just curious, maybe Dr. Paz and Ms. Hungeville first, what are your health plans doing in general to ensure that providers are aware and that patients have access to some of these covered non-opioid treatments?
So thank you very much for the question. So we, as you indicated, cover these types of devices for patients that appropriately fit the criteria. Where we spend a great deal of our emphasis at our opioid-wide task force is really looking at patients with acute pain, because that becomes the entry point for them being exposed to opioids in the first place. And that's where alternative types of, my colleagues mentioned, alternative types of treatment come into play: physical therapy, chiropractic, osteopathic manipulative therapy, different types of approaches, the use of non-steroidals, SSRIs, for example. These are things that we can do for acute pain, and frankly, there's data that shows that some of the over-the-counter treatments of pain, acetaminophen even, non-steroidals, can be equally effective, if not more so, for the treatment of those situations. When a patient has long-term chronic pain, that's a different matter altogether, and quite frankly, in those situations, if we think it's appropriate, we'll cover opioids, because that may be the only treatment that's effective. But certainly also, if a physician is recommending or prescribing a device, that's something that would be covered as well.
Ms. Hungeville, do you have are there any barriers to non-pharmaceutical therapies for chronic pain that currently exist, or can you expand on?
It's in awareness, and through our case management, we're trying to educate providers as well as our beneficiaries that there are alternatives to the opiate treatment, and so that is one of the interventions that we employ, to make them aware of other alternatives.
Good. I mean, this seems to absolutely make sense based on the testimony we're hearing, so I appreciate your perspectives, and yield back.
Mr. Reed.
Well, thank you, Mr. Chairman, and the question I would have is to Dr. Benjamin. I'm sorry, is that it?
Benjamin.
Okay, thank you. I appreciate that, Doctor. Question I have for you is pain in and of itself. Is that a bad thing from a physician's perspective?
Depends on the condition. If it's acutely, it's always an alarming sign that there's something happening.
So as a physician, and I see two doctors up there, as physicians, are you trained to, what's a successful outcome of pain management? Zero pain? Or is there some level of pain that to me is a natural response of the body telling a doctor, hey, there's an issue here? And are you are doctors, physicians trained to over-medicate in order to get to an unlikely outcome of zero pain, which is probably not, in my humble opinion, the best outcome that we can anticipate from physicians?
Absolutely, Congressman.
So could you explain on that a little bit?
Yeah, this is how part of the reason why we got into this crisis is, all these regulations that we had by the hospitals. If you remember, there was a time they used to call it pain is the fifth vital sign.
Mm-hmm.
I mean, it cannot be
Where
any
do those
more.
regulations come from? Government, right?
From government,
We
right? And then implemented
we
by
directed you to get to zero pain, didn't we?
right. So that was enforced in the hospitals. All the accredited health institutions needed to assess and address pain to a point that the pain level will go down to anywhere below 4. Now, as you know, that's a very subjective number. Mm-hmm. And if you look at Medicare, actually, they never talk about the regulations. They usually they never talk about the numbers. They talk about quality and function of the patient. So I think we need to shift this emphasis towards quality of life and function. And those are the tools that we use in our practice. And we rely much less on that number unless it's required by a lot of insurance companies. I'll give you an example. Congressman mentioned about spinal cord stimulator. We have this arbitrary number of 50%. If the patient's pain didn't go from 8 to 4, well, then his implant will not be approved, right?
So as we learn from that experience going forward and setting policies going forward, could you provide me some insight as to how we would do the new regulations to encourage a better outcome than what we may have, by an unintended consequences, made in good faith to limit pain, but had an unintended consequence of exacerbating this
Absolutely.
problem.
Unintended consequences. That's what we are facing. And that's why I was mentioning to Mr. Chairman that we need to, if we are looking for a solution, there is no one magic wand that we're going to wave here and solve this problem. This has many aspects to it. As Governor mentioned, I like that four pillars of the treatment or this, how to address this issue. And you got to work on the prevention. You got to work on recognizing what is the disease. Is the patient having a substance use disorder? Treat that, treat the consequences, prevent disasters, and limit the supply. If you look, the studies have shown that when limit the supply, we have less of a prescription writing and less deaths.
Thank you very much for the input.
Mr. Renacci.
Thank you, Mr. Chairman. It's interesting what my colleague, Mr. Reed, mentioned, because I was 18 years old in a horrible motorcycle accident and went to school the next day with a bottle of aspirin. It's amazing how government has changed things. But anyway, I've introduced legislation with Congressman Mark Meadows. It would enact a 7-day limit on opioid prescriptions for acute pain, and with some exceptions. It was crafted in consultation with over 30 stakeholders to address what studies and researchers have proven time and time again risk of addiction increases with the length of your opioid prescription. Dr. Paz, in your testimony, you state that Aetna limits opioid prescribing for acute pain to 7 days' supply. CMS has recently proposed limiting initial limit fills to 7 days. This would apply for all new opioid users in Medicare, as well as require plans to implement a hard edit for beneficiaries prescribed more than a 7-day supply of opioids. Dr. Paz, what research led to Aetna's decision to adopt a stricter threshold before Medicare proposed it?
So this is in our commercial plans, and we base that on the CDC recommendations. Those are the same recommendations that we share with physician and dental super prescribers who are prescribing large quantities of opioids to our members as well. We think that that's very important guidance. It's something that should be used by the provider community, by physicians and dentists who have prescribing privileges, and we felt the first place to put that in place was in our commercial plans where we could in fact do that.
So do you believe limiting opioid prescriptions for populations other than Medicare beneficiaries, I think you've said this, would have an effect similar to what CMS is hoping to achieve with Medicare beneficiaries?
So I would say that there's one exception to that, Congressman, and that's in individuals that are not suffering from acute pain, but in individuals that are terminally ill with cancer, for example, in hospice. There are circumstances where there are very good reasons to have long-term use of opioids. But we're focused here, and most of the situations we're looking at are, in fact, really 35% of the population are coming to us with acute pain situations.
What's interesting, my bill provides exceptions for cancer treatment, hospice care, palliative care, and chronic pain. The next question is for any of the witnesses, what exceptions would you all recommend for CMS as well as Congress should consider as a nationwide prescription limit? Other than those four. And as you mentioned those, are there any other exceptions that anyone on the panel thinks we should have? Okay, I yield back.
Mr. Thompson.
Thank you, Mr. Chairman. Dr. Clutter, you heard about the spoke program, hub program with the spokes. What can we do or do better at the federal level to enable the success of this program rather than to impede it? I have a county that I represent, Lake County, which is contiguous to your second home, that has a high opioid, terribly high opioid problem. And what can we do to make sure that they have long-term access to these services? And can you talk a little bit about the barriers in the Medicare program that would prevent treating those patients?
Sure. So we heard quite a bit about the Hub and Spoke program from Governor Scott. It's a fantastic program. Baymark happens to operate 3 of the 6 hubs in the state of Vermont, so we're very fond of it. And we are developing 4 of the 19 in California. While Vermont is a very small state, they've created what seems to be a no-brainer. This is one of the most effective approaches to treating the opioid epidemic we've seen in the treatment community. So what can Congress do? Well, as I said in my testimony, Congress can pass legislation that would allow Medicare to cover treatment services at OTPs. OTPs are the hubs within this hub and spoke program. And the concept is that you get a hub where all 3 federally approved medications can be provided, and wraparound services, including counseling and drug testing and other supportive services are provided. And then patients are admitted at the hub, they're stabilized there, and then once they're stabilized, they're stepped down to a less restrictive model of care, level of care, and those are the spokes. Those are primary care physicians generally. And the reason that the model was created was because, as we know, many primary care physicians have been reticent to prescribe medications to folks with opiate use disorder because it's a complicated disease and requires a lot of attention. The beauty of the hub and spoke system is that the hub provides services in the form of a MAT team, a nurse and a counselor, to the spoke so that the physician has additional resources in dealing with the patients, in helping the patients manage their medications, making sure they're not being diverted, making sure they're taking them on time, making sure they're participating in all the services like counseling that are required for effective outcomes. So coverage in Medicare is important, and we work quite a bit with SAMHSA, who has been helpful in developing more OTPs around the country. The Cures funding that came out of Congress last year, or this year, has been used in California primarily for developing this hub and spoke model. It's being used in other states to develop the hub and spoke model. So we would encourage you to look very closely at how states are using their Cures funding and make sure that they're using it in ways that are evidence-based and are in fact intervening in this epidemic and reducing overdose deaths.
Thank you. Yield back.
Ms. Jenkins.
Thank you, Mr. Chairman, and thank you all for being here today. I've introduced a piece of legislation, it's bipartisan, called the Furthering Access to Coordinated Treatment for Seniors Act, or the FACTS Act, which helps to bridge the gap in communication between the clinical setting where patients are diagnosed and prescribed medication and the pharmacy setting where patients receive their medications. In particular for opioids, having information about hospitalizations due to medication mismanagement can add in another layer of support from the Part D and pharmacy community. This coordination is something that is desperately needed in fee-for-service Medicare, and I really look forward to advancing it here in the House. With that said, Ms. Hungeville, as I understand, standalone Part D plans cannot review Part A and B claims data. Is that correct?
That is correct.
And Medicare Advantage prescription drug plans can review A and B data plans. What type of challenge does this lack of data present for standalone Part D plans in managing the benefit of a potential opioid abuser? And what could plans do to assist beneficiaries in claims if data were made available?
Well, we're limited into identifying those members that are at the greatest risk. In our members, in our Medicare Advantage plan, we are looking at their prescription utilization, we're looking at their hospitalizations, we're looking at their ER, and we are predicting sometimes with their first opioid prescription whether they are at risk for developing into addiction, and we're putting them into our treatment algorithms. In our standalone Part D plan, we don't have that visibility, so we have to rely on the traditional multiple prescriptions from multiple pharmacies and multiple providers, so we're not able to intervene as quickly as what we would like and hopefully prevent addiction rather than be treating addiction.
Okay, thank you, Mr. Chairman. I yield back.
Mr. Blumenauer.
Thank you very much for being with us this afternoon. Lots of things to chew on, but Dr. Paz, I really appreciate your reference to the legislation we have to try and make sure that we take care of this disconnect between people who, in terms of unnecessarily restrictive information for prescribing physicians to actually know that somebody's got an opioid addiction problem. I think the legislation that we have would help remedy that. Do you have any sense why this is so hard to remedy? Is this just because anytime we're dealing with patient privacy that we're in kind of a never-never land, that it hasn't received a high enough priority? I mean, are there examples that you or any of the panelists can help us with to show the disastrous consequences of a physician not having this information?
So, Congressman, thank you for the question. I think there are two parts to the answer. First is the general backdrop of a lack of interoperability of health information in general. We have real challenges in healthcare in terms of connecting data that sits in different places between providers with the patient, and often having patient information that is patient-centric, that is usable by a patient to make important health decisions. That's a challenge that's historical, long-standing, and in fact has become even more complicated with the use of electronic records to record and retain that information. So that's one issue. It's the backdrop for the challenges we have in really improving care in general in terms of wastefulness. But the other part of it is the Part 2 reform that I'd mentioned in my testimony. HIPAA was written for many, many good reasons, and obviously we're in support of it, as I'm sure everybody is, to protect patient health information. But at the same time, we have to have modernization of federalization around health information privacy so that in certain circumstances, like the one we're talking about today, providers, physicians have access to information to know if their patient is abusing or addicted to opioids so that they can make the important decisions they need to make to assist and help their patient. Absent of that, they're operating without the useful information they need, and in fact, that's to the detriment of their patient.
Mr. Chairman, I think this is just one area that it speaks to a larger set of challenges, but I'm hopeful that shining a spotlight here, we can help avoid potentially disastrous consequences, but maybe it'll guide us towards a broader conversation about some adjustments we can make to protect the confidentiality we all care about, but not make it unduly restrictive in terms of people being able to do the job for their patients.
Mr. Chair, may I interject? Very briefly, this is one of the problems, Congressman, with the prescription monitoring program, which we have limitation in accessing the private data from addiction management facilities. And those are not reflected in prescription monitoring programs. And a lot of small mom and pop type of pharmacies, they are not reporting to the data center. So, and again, this is a state-run program. And as we, as I mentioned in my testimony, we like to see a national program so that the states can interact with each other. People who live in, border cities, they can easily cross over and get prescription from two different providers, and the providers not even know what is going on.
Thank you. Mr. Marchant.
Dr. Kletter, I see that your company is headquartered in Louisville, Texas? Yeah. That's an area, my entire northern border of my district. So can you tell me a little bit about the program that you provide to my constituents in Texas? And tell me a little bit about the opioid situation in Texas, specifically North Texas, if you could.
Sure. Well, I can tell you that the program that we operate in Louisville in particular is under our Applegate line of business. And Applegate is an office-based practice that provides medication-assisted treatment, which is buprenorphine along with counseling and drug testing. So it's sort of a hybrid between an opiate treatment program, which is a very highly structured program, and a typical office-based practice, which is a primary care physician prescribing medications. So what we do there is we prescribe medications and counseling, and we do counseling and do drug testing to, it's a smallish number of folks so far. We've been open in Louisville for just a short time. We have 12 sites in Texas in total. Most of those sites are opiate treatment programs. And again, opiate treatment programs are the more structured, more regulated programs where we have more intensive services and we provide daily medication administration. The daily medication administration is part of the federal regulations that helps to prevent diversion of these very powerful medications. So what that means is a patient will come into treatment, they'll get a history and physical with a physician, they'll be provided a clinical assessment, generally an ASAM assessment, American Society of Addiction Medicine assessment, or Addiction Severity Index assessment. There'll be determined or diagnosed with opiate use disorder, and they'll be provided with the appropriate dose, the appropriate type of medication, and the appropriate dose of medication based on a physician's order. And based on that physician's order, they'll then they'll develop a treatment plan with a counselor, and every 90 days that treatment plan will be updated so that we can make sure that they're doing well, they're progressing in treatment. We'll do a monthly random drug test to make sure that they are not only taking the medication that we're giving them, but that they're also not taking other illicit or prescribed opiates. And they'll get their medication from a nurse every day who does sort of a very brief assessment, make sure that the dose is the right dose and that they're progressing well in treatment and getting some words of encouragement to follow their treatment.
And does Texas have an effective opioid policy as far as this assistance from the state?
The Medicaid rates for reimbursement for the services that we provide are not good in and of themselves, but they've done a great job in using the STR money out of the Cures Grant to supplement that program this year and next, hopefully. So generally, the regulatory environment in Texas is good. Funding could be improved, but they're working on that and they're doing better, and we're encouraged that they've been a good partner.
Thank you. Thank you.
Ms. Black.
Thank you, Mr. Chairman, and I appreciate you all being here today. As a nurse for over 45 years, I've watched this scourge on our society occur, and I know we talk about chronic pain. We certainly want to take care of people that have chronic pain. There's no doubt about that. They suffer. You can see that by their blood pressures, by their anxiety, by their pulses, but what we did with this, how bad is your pain, the smiley face was not a very good thing for us to do, and I'm glad that we have finally stopped doing that. Thank you, Dr. Beneman, for what you're doing with the interventional pain management. And I would like at some point in time, and I know we don't have enough time here, to talk with you more about the results that you're getting from that. What percentage of your patients going through that kind of treatment have found success? Is there a number that you could give me on that?
I would be glad to provide you with all the data.
Yes, I would really like that. Dr. Kletter, I want to go to you and talk to you a little bit about, or excuse me, Mr. Kletter, about, or is it Dr. Paz? Which one of you are doing the program where you're using the medication-assisted treatment, Dr. Kletter? Okay. What percentage of the clients that you have eventually become drug-free with your medication-assisted treatment? How do you move them to a drug-free situation?
So, as I said in my testimony, it's important to understand that medication, as we think about medication-assisted treatment, it's important to understand the concept of opiate use as a chronic disease. And so like any other chronic disease, we know that patients who suffer from opiate use disorder struggle with it in some cases for their entire life. We have very effective treatment, but we don't have a cure for the treatment. And so generally, our approach is not to encourage people to get off of treatment immediately. We do encourage folks to stay in treatment at least a year. And in that way, we know that all the science tells us that you must stay in treatment for at least a year to sort of help heal the brain from the changes that have occurred. We know from science that there's changes that have occurred in the brain from overuse of opioids.
Okay.
So we encourage folks to stay in treatment at least a year. I can tell you that 60% of our patients are in treatment.
If I could, I know my time is going to run out here in just a second.
Sorry.
If I could get more information from you on looking further out and what all the results are. And then Ms. Huntingville, I would like to ask you about how you are using telehealth, since that is something that I'm very interested in.
Well, we are piloting a program where in the ER, and trying to get patients when they've are in crisis, right, in overdose, or even drug seeking, and making telehealth available to them to immediately start with medication-assisted treatment and then get them into counseling and into a program.
I would love to hear more from you as well. And Mr. Chairman, I'm asking for a lot of information. I guess will be sent back to your office so that you could share with us some of the results of what you're doing. Thank you so much.
Thank you. Just a couple questions in summary. Dr. Kletter, in your testimony and in your statement, you used the phrase opioid use disorder. Is that a term of art? Is that somehow distinguishing between the word addiction and are you communicating something else? So I've got a brother who's an emergency physician, and I noticed at one point the emergency physicians began to speak about the emergency department. It's, okay, I got it, man, okay? So what's the story behind that phrase? And is there a subtlety that you're communicating there that we need to know about, or are these phrases, or is that interchangeable with addiction?
So opioid use disorder is the term that's used in the Diagnostic and Statistical Manual of Mental Disorders, the DSM, which is sort of the tool that physicians use to diagnose disease, psychological disease generally. There is a distinction between addiction and dependence that's really critical to understand. The difference is, of course, addiction, which is, so opioid use disorder is what you might call an addiction, and it's characterized by, in the DSM, there's 11 criteria in order to meet the diagnosis of opiate use disorder. 2 of those are physiological, the tolerance and withdrawal. The other 9 are behavioral, things like engaging in behaviors despite negative consequences, compulsive use, using increasing amounts over time even though you don't intend to. So there's an important distinction between opiate use disorder and tolerance, dependence. Dependence being simply using a medication consistent. You could be dependent on a medication. For example, I take a statin. I'm dependent on that medication to prevent my cholesterol from getting too high and having a heart attack. So I don't know if that answers your question.
Yeah, it does. But there's some subtleties there that I need to learn more about that. So if you have any insight on that, just the tutorial, I would be grateful.
Sure, we're happy to tell you more and invite you or Ms. Black or any of the members of the subcommittee to any of our facilities. We're happy to show you around, show you what we do and how effective our services are.
Okay, that would be helpful. Dr. Paz, in your testimony, you spoke about intervening for those who are at risk. How are at-risk either individuals, patients identified or overprescribers identified, and sort of what's the threshold, sort of based on Mr. Blumenauer's observations about the sensitivity around privacy and all that sort of stuff? How do you navigate through identifying someone who's at risk and, there we go, who's at risk and how do you walk through that carefully?
Thank you for the thank you for the question, Chairman. So there's several different ways we do this, and one is we have access to our members' claims history in terms of prescriptions of opioids, and we will find evidence of pharmacy shopping, physician shopping right there that would be a risk factor. We have records of his prior history.
So you've got basically predictive modeling. I mean, you've got that access to those algorithms that say, hey, there's a problem here.
And then we would intervene if there are circumstances where that occurs. Again, within the boundaries of HIPAA requirements, certainly.
What does that intervention look like? I mean,
well, we have case managers, care managers that we actually have that intervene with our member, for example.
Is it explicit? I mean, is it a call from a case manager that says, I think you've got a problem?
Yeah, we would certainly, our case managers would interface or interact with a member that has a set of conditions that require some kind of an intervention that we can offer, not as a provider though, which is key. We work with providers, and again, being mindful of HIPAA requirements.
So say that again. You were just making an important point, and I didn't quite pick up on it.
Sure.
So the important point that you're making is the distinction between providers and carriers based on what?
So in terms of prescribing, a provider would prescribe.
Right.
We have access to information that would suggest overprescribing, and I gave a few examples earlier of that, putting in limits on how many days a prescription can be written for acute pain, putting in a dosing limit as well. So these are things that we can do. We've done other things like partnered with a company, Pacira, which has produced a non-opioid pain reliever for oral surgery, post-oral surgery. We've created a partnership with them. It's a value-based contract that we have with them, so it's emphasizing quality outcomes for our members that receive that drug, but they're now going to receive a non-narcotic after oral surgery as opposed to a 30-day supply of a narcotic post-oral surgery, which interestingly in our review of data and analytics, we find that that does sadly occur. It occurs even after a routine dental visit, unfortunately. So for a wisdom tooth extraction. So there are a number of different things that we can do, and including, for example, we have 2 programs that are noteworthy. One is the work that we're doing with mothers who have neonatal abstinence syndrome. We launched this program in several states. Again, our care managers intervene with mothers who have been identified as being neonatal abstinence at risk for having children born with neonatal abstinence syndrome, and we put a program in place with ICUs, neonatal ICUs in their communities to address that. And certainly our program where we distribute naloxone and make sure that we're working to train first responders in communities to help members avoid death associated with overdose and addiction.
That's helpful, thank you. What's the duration, and this is for the physicians on the panel, what's the duration that somebody can be taking an opioid and they become addicted? I mean, so we've talked about a 7-day threshold. I've heard that referred to several times. You know, Doctor, you're shaking your head. There's not a magic number. What's a threshold? What's a range? What's a reasonable expectation?
You know, again, it all depends on who's the patient, what is the pathology behind the reason, what's the reason that the patient is taking the medication? Is it the patient who just feels aches and pains all over the body, or is the patient who has had 5 low back surgeries and 3 neck surgeries and 2 knee replacement? You know, these are all different patients. And, you know, we are human beings at the end of the day. We are not robots. So we react different to disease, and we react differently to medications for the disease. So we have to allow for individualization of these treatments.
In your study and evaluation of this, for any of the 4 of you, is there a spectrum in terms of addiction, or does somebody cross a line and they're addicted?
So in general, that 7-day number that is in the CDC recommendations is there for a reason, because roughly about, and this is again depending on the study you look at, about 14% of individuals who are exposed to a week of a narcotic will become addicted.
14%, so in other words, 14% of people who are on it 7 days or more they're in.
And Mr. Chairman, the psychiatrist will argue that addiction is a disease in the person, is not in the substance. So this is a continuous saga between one side of this equation and the other side. Yeah.
Yeah, I understand.
It also is important, the dosage, and the CDC guidelines also say that more than 50 morphine equivalent dosages per day put you at a higher risk of developing addiction.
Mr. Chairman, if I have to point to one thing that is missing in a lot of medical specialties, we are good in writing prescriptions, in prescribing treatments, but we are not good in monitoring the treatment as far as effect and side effect. That's why it's very important that when we prescribe, that's what our guidelines say, how you need to monitor the effect and the side effects of medications. That's going to be the key.
Yeah, that's a good summary. So let me ask each of you in closing, what's the one thing, if you had to communicate one thing, not 4 things, not a handful of things, one thing to this group today, what would it be? Doctor?
Cut the supply of heroin and synthetic fentanyl. That's what is like a weapon of mass destruction that affecting our communities.
Got it. Dr. Kletter?
Increase access to evidence-based treatment services.
Okay. Dr. Paz?
Ensure education around use of non-opioid pain treatments.
Okay. Ms. Hungeville?
And I would also add limiting dosages of opioids for acute conditions.
Okay. Mr. Thompson?
Thank you for indulging me. I mentioned to the governor my concern about the treatment delay in the workers' compensation programs leading to opioid problems. And it's something I'm very, very interested in. And I've seen a lot of anecdotal evidence that this is true. In my state, in California, there's just a long waiting period. Everybody's denied, I don't want to say, just a lot of people are denied the procedures that the medical profession recommends, so it stretches out the time that they're on painkillers. And I've just seen too many people who, because of this, become addicted. And I'm looking at some different things to try and deal with this. So if any of you have any information that would help me out in that, would you please send it to me? Thank you.
We've been joined by our former colleague, Ed Whitfield, a great American from Kentucky and former chairman of our partner committee, the Energy and Commerce, which has a lot to do with the solutions here, so it's good to have him back. For the record, members are advised that they have 2 weeks to submit written questions that can be answered later in writing, and those questions and your answers will be made part of the formal hearing record. And then finally, two things. Number one, thank you for your time. You've been very generous with your time today, and I know it's an adventure to schlep out here and all that, and thank you for doing that. And for the time that you put into your testimony, it was helpful. Secondly, if you think of things subsequent to this, you're flying home, you're driving around, you're whatevering in the next several weeks, months, and you think, I wish I'd said that, or I've got this article, I think those people would benefit from it, send it to us, and I'll make sure that it's distributed. You get the sense of the caliber of these people. These are serious, thoughtful people that are solution-oriented. We're not looking for pen pals, if you know what I'm saying, but you know, things that you think we should be reading, I think it would be very, very helpful. So on behalf of the whole subcommittee, I want to thank you for your time today, and look forward to continuing to interact with you in the future. Thank you.
Thank you.
The committee stands adjourned.